Good evening, colleagues. It's very good and nice for me to see you back in our journal club. I think we have to be consistent with this journal club for the sake of our learning commitment. And I do really think that everyone who are raising the hand, who have raised the hand to be the one to present by the voluntary action would be much appreciated. And we appreciate Dr. Eliza Nindita this evening for her concern to be the one presenting for our journal readings. All right, Eliza, how are you?
Hi, I'm good, doctor. Very well, thank you.
Thank you. Nice background.
Yeah, thank you.
And I thank Dr. Prita Hadi to be my co-host. In case there are people are in the waiting room, she would assist me by accepting them and bring them into our virtual room. All right, Eliza, you may start now.
Yes, sure. Well, good evening, Dr. Teddy and Prita, and hopefully some of the colleagues will join us later on. Well, as for today, I would like to share about hand tumors. Okay, so our journal club as go on almost every week. Then this day we will talk about hand tumors. It's not too, well, I'm just looking for a superficial about hand tumors. So this is just like a coffee table talking, I hope so. And we can share about cases or possibly about if someone might possible question about tumors later on. There are three journals that we will like to talk about. I would start with the Incidence and Anatomical Distribution of Hand Tumors, which is from Singapore, which is near from Indonesia. Why I choose this journal, because it's still in Southeast Asia. So possibly we have almost the same cases, I believe, compared to Singapore and Indonesia. And the next journal would be the clinical decision making for a soft tissue hand mass, when and how to biopsy. Just as for a reminder that hand tumors, when we do the biopsy and how to make that biopsy accurate to have the diagnosis. And the third journal would be the bilateral plexiform neurofibromas of the posterior interosseous nerve mimicking dorsal wrist ganglions. Well, it's just an example of a case that we might consider a differential diagnosis of other tumors in the hand. So I might start with the first journal, the Incidence and Anatomical Distribution of Hand Tumors, a Singapore study. So as an introduction, the hand tumors are encountered frequently both in primary healthcare and specialist clinical practice. Well, the studies from this journal suggest that 15% of all soft tissue tumors are located in the hands region, and 6% of bony cancers occur in the hand. So hand tumors are potentially cause functional impairment. This is why a bit important for us to reminder about the hand tumors. Well, here the list of differential diagnosis of the most common hand tumors based on anatomical location that would be helpful for clinicians. That this journal would like to see if there is a correlation between tumor types and the anatomical distribution in the hand, which potentially aids in diagnostic decision making. Many patients seek medical consultation because of the cosmetic appearance of their hands or anxiety over the possibility of malignant growth. Well, any lumps we consider as tumor, and usually patient would be concerned that if that lump would consider as a malignancy. So which is why as a reminder about the hand tumors. This study is actually a retrospective study from Kotek Puat Hospital, which conducted from June 2010 to December 2012. And the data points collected were It's in gender, the tumor location, the site of laterality, the duration of symptoms and time interval, and histological diagnosis. And histological diagnosis specimens is read and qualified by the pathologists at Kotek Wat Hospital. So this is a profile from the first table of the journal. There are 115 patients joined the journal, but there are 116 hand tumors that were excised from 115 patients within the period of study. So the female, 65 patients, and the male are 50 patients. Most of the ethnicity of the patients in the Singapore are Chinese, as most of the population. And the laterality of tumor is almost the same compared right to left. And here are the types of tumor that excise by location. So they divided into 3 groups. The first group would be the distal to the metacarpophalangeal joints, or MCPJs. And the second group is consisted of tumors from the proximal to the MCPJs and distal to the carpometacarpal joints, CMCJs. And the third group would be proximal to the CMCJs and distal to the radiocarpal joint. So it's not more proximal to the wrist joint. And as we can see here, that the distal to the MCPJs, which is 39 in total, 39 tumors that were excised, and the most of the tumor founded a giant cell tumor of the tendon sheath, which is 28.2% of the patients. And the second one is the ganglion cyst that consumed 7 patients, which is 17.9%. And the others is just not so many cases. And as for the most of the cases here, as we can see that I highlighted into the red box, that it's between the CMCJs and the RCJ, is 59 from 66 patients, which is most of the patients is 89.4 patients in total. So this ganglion is actually make the most of the tumor out of 116 tumors that we can see. As that results from the table, the most common tumor is the ganglion, which get the 66 tumors out of 116 tumors. And the second would be the giant cell tumor of the tendon sheath with the GCTTs, comprising 9.5% compared to 116 tumors. And out of 116, there are only 2 that arose from the bone, while the rest were the soft tissue tumors. That was, sorry, I will get back to the table. It's one of the exostosis. It's from the bone, and they don't mention the next tumor that got from the bone. And in total, they were reported to be benign. There's only 1 tumor that found to be malignant, and it was an epithelioid hemangioendothelioma that is excised from the right little finger metacarpal diaphysis of a 56-year-old man. So here we can see that most of the hand tumors are benign and rarely to be malignant, although it's rarely, but though sometimes we should consider malignant sometimes, because most of it are benign. They put a profile patients in table 3, comparing the most common tumors that are excised from the hand, which is the first one is the ganglion, and the second one is GCT, but they don't have any statistic numbers to compare in this table. They just want to let us to see that The age, it's mean 35.9, and the ganglion is 38.9, and the gender for the GCT most likely in male, and as for the ganglion most likely in female, but they don't have any significant relations. So, and also the laterality of tumor, that in GCT most likely in the right hand, and as for ganglion, slightly to be on the left hand. And all of these patients of ganglions, 42.5% patients from the 66 patients, they don't complain any pain. And so as for discussion in this journal, the benign tumors are make most of the cases compared to malignant tumors of the hand. And however, the actual incidence may be higher, as we know that only less than half of the patients come as asymptomatic and might not necessitate any excision. So they don't, they might not come if they don't have any symptomatic complaints such as pain. So which make that less patients to know or to give the limitations of the study. So the study suggests that distal to the MCPJs that we are considering to diagnose as GCT because there are more commonly excised than ganglions. And recurrence rates are high for common hand tumors. It is important to consider likely differential diagnosis, as they can help clinicians to better plan surgical treatment for patients. So the limitations of this study include it's just a retrospective study, which include only patients who underwent for surgery. And its shortcoming was that small number of patients enrolled, possibly due to they don't have any complaints, so they don't come to the doctor to have to get more of the diagnosis. So it doesn't come with, so we don't know actually how many patients, it possibly more than the journal itself. So as conclusion, most hand tumors were benign. The ganglions were the most common tumors between the CMCJs and the RCJ, while the giant cell tumor were the most common tumors distal to the MCPJs. That's for the first journal. Shall I continue, or there is any question before?
I think it's going to be good to finish all the reading
Okay,
and then
sir.
continue with the Q&A.
Okay, so I would like to do the next clinical decision making for a soft tissue hand mass, when and how to biopsy. So it's actually, I know that it's doing a biopsy usually with a tumor that most of the tumor we will do a biopsy. So as for this, a proper diagnosis and treatment for a soft tissue hand mass is an integral aspect of any hand surgery practice. As a part of diagnostic workup, the decision to utilize the biopsy as a diagnostic and therapeutic treatment is a critical step. Hand soft tissue tumors are unique with respect to other extremity and axial located tumors because biopsy here simultaneously represent the last stage of the diagnostic workup and first stage of treatment. Evaluation of a hand mass and subsequent surgical treatment is a frequent clinical encounter for the practicing hand surgeon. The clinical evaluation of benign and malignant hand tumors has traditionally focused on diagnosis, surgical excision, and reconstruction. And actually, there are no guidelines for doing a biopsy for the hand tumor itself. There is no specific guideline talking about a hand tumor itself. Well, this make that we went to require a biopsy, which makes the questions here actually. So a biopsy is still indicated whenever a mass has a biological activity or cause symptoms in the patient. Atypical features of benign pathologies include painful lesions, especially at night, and those with progressive size. Physical examination, noting size, shape, mobility, consistency, exact location, and changes to overlying skin may alert the clinician to a malignant process as well as any neurovascular symptoms from tumor or mass effect. The goals of the biopsy are to generate a tissue sample for accurate pathological analysis and begin the therapeutic treatment of the tumor that is causing pain or a disruption in cosmesis or function. Okay, we start from the physical examination as for a start that every reminding that every diagnosis, we do start with the anamnesis and then the physical examination before we do any biopsy to do a diagnosis or even the treatment. So these are for doing a transillumination that we want to see as is, for example, is it like a cystic or what kind of mass do we have? So the first picture, the A1 is the passage of light through the digit in the absence of a mass. And B as a solid mass at the level of proximal interphalangeal joint that does not allow passage of light through the mass. So we might consider that's like a solid mass that's possible in the finger. And for the this as for the example, if we want to preparation of the biopsy with doing an excision biopsy that we need to give giving like a specific label, so it's not going to be mistaken by the pathology. So prior to sending a specimen, it is advantageous to label a specimen when margins are important for treatment. The technique involves marking orientations with suture identification, for example, of proximal, distal, and as well as superficial and deep if the skin cannot be seen. Due to this is a three-dimensional mass, so don't forget to pointing out which the most important that we want to take a look from the pathological examination. So this image is the biopsy demonstrating that for the picture of A is a superficial and the B is the deep surface of the biopsy specimen. So don't forget to give the orientation is marked by a different sutures, demarcating of radial and distal aspect. And we have to mention that on the form that we need to fill in for the pathological examination. So here is the clinical characteristic of common hand and soft tissue determinate of masses. For the most, before we talk about the most of the prevalence is the ganglion cyst. So it's a soft mass and the typical locations is usually in dorsum and the radial volar wrist, and it gives a positive transillumination test. So it's like the before picture that gives, we give a light and they will give a positive transillumination test. We can add another imaging, for example, like an MRI to prove that it gives a periphery enhanced with gadolinium, not the lesion itself, but it's just like give a round, smooth lesion, dark, for an extra imaging that we can have to just make sure the diagnosis. And as for like a lipoma, if we consider differential diagnosis from the ganglion cyst, then it is actually giving a negative transillumination test compared to the ganglion cyst. And for lipoma, there gives a rubbery texture and usually it's mobile compared to the ganglion cyst. And for the X-ray, they give the imaging.
Bunyinya kata keprek sekarang.
And as
Udah
for
sebelah kiri aja, kiri depan aja.
for the X-ray with lucency of mature fat, the variable location is usually a subcutaneous, intramuscular, or in deep space of the hand. So the MRI give a similar uniform appearance of subcutaneous fat. And it's usually in the moderate to, for the MRI, the T1, they give a bright signal, and the T2, it's moderate to bright signal, suppression on fat saturation sequences, and well circumscribed. But usually lipoma and ganglion cyst can, they don't give any pain unless ganglion cyst possible to give pain, but most of them don't give any pain symptomatic. And both of them are slow growing, and it's usually it's in just in the soft tissue. So it's as for the giant cell tumor of the tendon sheath, they also give a painless symptomatic and also a slow growing mass, but it gives for the physical examination, it doesn't give the transillumination test also, because they it's a solid mass for the GCT, and it's usually small and a firm palpable mass, and usually cover the tendon sheath and give pain if it covers the tendon and it limitation the movement, and because of pain, because it covers the tendons. And as the MRI can give a well circumscribed with nodular or lobulated pattern with low signal intensity on both of T1 and T2. So that's the three diagnoses of tumors that I would like to emphasize, because that possibly the ganglion cyst and the GCT are the most tumors that we will possibly get out in our clinical settings. And this is the example of the preoperative image of a tumor bed, a re-excision of malignant mass in the tenor eminence. Well, the journal doesn't really explain why they do a re-excisions of the malignant mass, but this it's just to a reminder that although the overwhelming majority of hand masses encountered are benign, as we know, most likely to be benign, but identifying the estimated 3 to 6% of malignancy is of utmost importance. So there is still possibility to be a malignant tumor on the hand. So at the picture that we can see that the initial incision of the tenor eminence with the planned white margin treatment, and then a greater morbidity seen on the post-operative image. So even though it's a small chance to be malignant in the hand tumor, but we still need to sometimes consider if we think that could be a small chance to be a malignancy. So excisional biopsy and open incisional biopsy can have several complications relating to sampling of surgical tissue, which include infection, wound dehiscence, hematoma, tumor spread, and contamination of an uninvolved compartment, neurovascular injury, inadequate tissue collection, and inadequate margins. The vast majority of soft tissue tumors encountered in the hand are benign and can be treated with excisional biopsy. We recommend a classification, the journal recommend a classification of a mass based on clinical features and advanced imaging. To determinate lesions can be treated with an excisional biopsy, and indeterminate lesions may be treated with a needle or incisional or even an excisional biopsy. So it's just, so in this journal, there are also consideration to do classifications to get a clinical features and what to, but kind of biopsy should we take. Okay, so that would be the second journal, and I would read the third journal. Is an example case of a bilateral plexiform neurofibromas of the posterior interosseous nerve the mimicking of dorsal wrist ganglions. This is one of the most cases that hand surgeons usually get and hand tumors of ganglions. Risk for the dorsal wrist pain and swelling, usually it's like a frequently encountered by hand surgeons in clinical settings. Overall, solitary neurofibromas carry a very low risk of malignant transformation, but in the setting of neurofibroma, eventual transformation into a neurofibroma sarcoma is more common. This article describes the case of a young woman who presented with symptomatic bilateral dorsal wrist masses initially diagnosed to be a ganglion cyst, and years later, she was found to have a neurofibroma on her chest wall. And so it came up a further workup of her dorsal wrist revealed a pin neurofibromas, a posterior interosseous nerve neurofibromas. So presenting a 33-year-old woman presented with bilateral dorsal wrist masses associated with pain and limited range of motions. On initial presentation, the masses were believed to be a ganglion cyst and the patient opted for observation. So it was noted a cystic prominences on the dorsal wrist bilaterally for over 10 years previously, before she came with the initial presentation. So over the last 2 years prior to presentation, she reported increase in pain and size. And 3 years later, she was found to have a chest wall mass diagnosed by biopsy to be a neurofibroma. So she later returned to seek treatment for her wrist masses, and the MRI demonstrated posterior interosseous nerve neurofibromas. A dorsal wrist masses situated over the scapholunate interval are commonly attributed to ganglion cyst, which is why on the initial presentations, the mass were believed to be a ganglion cyst and it's just opted for observation and no further need to treatment. This is the MRI of the patients at the 3 years after found it to be a neurofibroma. The MRI demonstrated an oval, elongated enhancing mass located between the third and the fourth extensor compartments that was consistent with peripheral nerve sheath tumors. The mass measured approximately 1 × 1 × 3.5 centimeters at anteroposterior, transverse, craniocaudal, and had a dumbbell appearance with a waist at the level of the radiocarpal joints. So here the clinical of the tumor, that the mass involves segment of the pin that was excised. And after the 6-week follow-up, she had a full range of motion of the wrist and no residual dorsal wrist pain or sensory deficit. The pathology was consistent with a plexiform neurofibroma. So the patient underwent surgical excision of the left wrist pin mass. This is because she was complaining of the bilateral, and the right and also the left of the hand. So this is the third and the fourth dorsal extensor compartments. This is the right hand between the third and the fourth dorsal extensor compartment. And as we confirmed the mass, it was originating from the pin. The mass with the involved segment of the pin was excised. And then there is no further complications. The presenting symptoms of a neurofibroma typically involve a combination of a palpable mass, loss of nerve function, and or pain. The pain is typically severe and greater than that seen with just a ganglion cyst. But at this case, the neurofibromas of the pin, although it's rare, well, still should be considered in the differential diagnosis when a mass elicits pain with percussions, fails to trans-illuminate, fails aspiration, or if the patient has a history of neurofibromas elsewhere in the body. Thank you for the chances to talk about hand tumors. And I hope we can discuss a lot about the basic of the hand tumors. Thank you, Dr. Teddy.
Thank you. That's great. So you spent half an hour to present the 3 readings, which is good, and could get like the main message from those 3. The first one was telling us about the epidemiology of benign tumors in the hand, although it involves the distal part of the forearm, but it's still considered the hand because most of the cases appear to be ganglion. Although ganglion is not really in the hand region, but this is the hand surgeon or plastic surgeons and general orthopedic surgeons, and most of the general surgeon also deals with this kind of tumor, which is good to know. Also the aspect of differential diagnosis, as the last case has showed us the importance of considering the differential diagnosis, while the second part of the readings tells us about the concern on making biopsy as part of our management dealing with mass in the hand. All right, so thanks to our colleagues to be able with us, joining us with this journal club. I think now we could discuss the topics, and I have seen that Dr. Lina has started to ask questions in the chat box. Is there any tip and suggestions how to prevent recurrent after ganglion excisions? I think I would invite Dr. Lina herself to give her own opinion in her practice, whether she has observed that the recurrence is difficult to manage or to reduce. Hi, Lina. Are you there? We know that Farah was moving around with her car, maybe getting in touch with the parking lot to stop and listening. But I'm sure Lina is sitting still.
Yes, doctor.
Hi, Farah.
Hi. Sorry, I'm late.
No problem. We could detect your baby bands moving around. It was
How do
good
you
to
know
know
it?
that.
How do you know it?
Yeah, we have
How do you
satellite.
know? Huh?
So our journal club is equipped with satellite. So we know everyone in the group, 90 people in our group, whatever
Really?
they're doing during the
Kidding
meeting.
me.
All right, so Lina, are you there with us?
She can only type, so.
Okay, yeah. She might be busy helping Pak Jokowi in State Palace this evening, which is good to know that. All right, so do you have any comment?
Yes, well, regarding from the journal is, they also mentioned that the recurrence of the high rate of the common hand tumor, and it is important to consider also likely a differential diagnosis if there's like a recurrent, the recurrence, but for a ganglion cyst, because of they don't do a surgical, all of the ganglion cysts, if they don't have any symptomatic, they don't do any surgical treatment. So they only do like, such as if there's no pain and no in movement, there is no complaining, they don't do anything about the cyst, they just keep the mass there. But if there's a complaint, then they do a surgical excision. But before the surgical excision, they usually just aspirate the cyst, and that usually gives the recurrence rate so high for the ganglion cyst. Or if this, they don't mention how many recurrent, and then they do the surgical excision itself, but they would do an excision if there's a complaint from the patient, such as pain or limited in movement.
All right, so can we get further information in regards of their patients who are merely complaining about the aesthetic appearance?
Yeah, but they don't and then after the journal, they don't even mention about the aesthetic anymore. But usually just because they're afraid of they highlight it more of the mass, that giving the anxiety of the patient, that afraid it's gonna be a malignant, so they do excise the tumor by because of
Right.
the patient asked.
Okay. So any other from the audience who would like to provide comment based on your experiences? Well, in my own observations, I got some stimulations back more than 10 years ago, maybe more than 15 years ago, when a friend of mine got ganglion excisions by me and then met another colleague and got criticized that it's supposed to be not recurrent. That was the time when she came with recurrence after more than 5 years. And the statement from my colleague was really put me into searching of the literatures. So I haven't updated my own understanding that ganglion has a high rate of recurrence. And how high the recurrence is more than 60% if you do it by open surgery. If you want less recurrence, then you may get 40% of recurrence by performing endoscopic ganglion excisions, specifically with the raised area, be it dorsal and volar side. So by evidence, we need to tell the patients from the very beginning that there is no point to prevent the recurrence to be zero, because the evidence shows that its recurrence level is quite high. You know, we do not expect like 5% of recurrence if we got one patient among those 5% of the population. But then this is not about 5%, this is about 40% and even greater in the open surgery. So what I do in my own personal practice is that I put my patients in a good cooperation before I came into a real surgery to her or to him. So he should or she should be aware that I would put the hand in movement restrictions for the first 3 weeks. After that, you know, put the pressure bandage for 6 months. Most probably it might not be comfortable, but it would be good for them to have a reminder with that, you know, wristband in their wrist that, you know, he or she needs to limit the movement, meaning that, you know, they cannot play tennis, they cannot play, you know, high impact activities, and also with the modifications on the ergonomy when they do their job. If it relates with typing, computer work, I mean, behind the desk work or whatever, and also with other activities related to the wrist, when it really relates into the, you know, repetitive action that comes into frequent activities. That would include also sport activities. All right. In terms of the intraoperative surgery, I've been doing for the past decade with non-tourniquet technique, as you may aware, and it's fantastic to use tumescent injections, which in general, you may need only inject 6 to 8 milliliters of tumescent injections. In my case, I use 1 per mil tumescent formula. Then you could recognize all the details. And during the management of what do you call the base of the ganglion cyst, so the capsule, you need to marsupialize, meaning that you stitch it properly to the surrounding tissue by avoiding stitching it into nerve fiber or blood vessel. Then make sure that it's going to be in an opened channel or ostium from the joint part where tendon is actually starts from the synovial sheath defect. So that defect as the base of the ganglion needs to be properly open. So then the productions of the fluid, the gel, would be absorbed properly while putting the hand for 6 months in pressure garment for the wrist. That's in my best practice so far, which I do not provide myself and the scientific community with proper statistic data based on research. But then that's level 5, at least from my side.
Yes, doctor.
Thank you. Well, Dr. Lina proposed that, proceed with the discussion. What I do is what she does is to explore and follow the ganglion until the joint. Oh yes, that's the same with what I was telling, that you need clear operative field, that you make sure that you cut the base and then you properly stitch the opening, yeah, to be not easy to be covered again or closed, all right? So whenever it's covered by scar tissue, then let it be, but it's not by the original remaining or remnants of the capsule. Okay, I
Yes.
would invite others to give opinion. All right, so GCT is another discussion during the reading, and it is good to know the specification of this GCT, and the reading has told us in regards of how to diagnose GCT, and mostly the GCT involved the distal part, in the hand area, not in the wrist area, or I got it wrong?
No, sir. Yeah, I mean, it's GCT in the hand, yes.
Right, and the case is related to the tendon sheath, it's not the bone.
Yep.
Yeah, with its tendon sheath, it's considered as benign, and it's quite rare to transform into malignant case. The main problem is with the pain.
Yeah. But do sometimes that I ever actually in my practice, sir, I did found that the GCT that involves the bone. So the bone is actually get what do you call it, a concave. It's so I have to retouch the bone because of it involves to the finger. I mean, it was in the middle phalanx at that time. So yeah, so I think do sometimes it can involve the bones, I think.
That's true. That's true. GCT in the bone needs more attention rather than GCT in the tendon sheath, which we are calm enough to understand this is benign lesion.
True.
The GCT in the bone has higher recurrence rate.
Ooh.
That's one of a point where you need also to consider excisions. Complete excisions of the part of the bone that is involved in a tumor. So then further and more work with the reconstructions would be needed rather than leave it behind by curate touch only, but then the recurrence is very high. I would say very high. So this GCT in the bone also has more obvious chance to transform into malignancy. So that's why taking care of GCT originated from the bone is more with attention.
Oh, I see. Yes. But
Right.
also in the soft tissues, or because I also experienced a patient that come for it's said that a recurrent ganglion cyst, but then it's actually a GCT tendon sheath at
Right.
the dorsal part, because it's still in the dorsal part, and because of a darker skin of the patient and a thick dark skin, sometimes we cannot do the transilluminate because it doesn't give a good light, so we cannot see it's actually transilluminate. So the previous doctor was thinking it's about cyst, and I don't blame them, because and I did the transillumination and I also cannot really see, but then I open it's actually a GCT.
GCT. All right.
Yeah.
Okay, now I would like to Yeah, I would like to share with you that you may find in the literatures about malignancy in giant cell tumor in the bone. So that's why it is important to realize that you are not dealing with a simple benign lesion when you are dealing with GCT in the bone, right? This
Yes.
is about a review of the literature in
2009.
2019, which is quite new of the journalism. Yes. So it is important to realize this. So not only about recurrency, but also about the transformations into malignancy. Any other point in regards of the diagnosis for JCT?
No, I think they usually make a comparison between the GCT and the cyst, the ganglion cyst, because some still do. They make just because of those two most come often, and also people within the same region at the dorsal and the radial side of the hand, and they usually comparing between GCT or a ganglion cyst. But they do only an excision and doing a biopsy, and mostly come in benign, I think.
All right.
Mm-hmm.
So for the sake of continuing learning, it's going to be good to ask any volunteer from the audience whether you're going to be uh, providing yourself with journals that discusses about GCT in the bone, I mean, originated from the bone, and the reconstructive aspect on how we deals with those cases.
Yes.
Maybe any of you in the audience would like to raise your hand. We could help you with the literatures if you could not find any. What about Thomas? Thomas, are you there with us?
Yes, sir.
So are you willing to take this challenge for the reading, for the next reading?
I'm not sure, sir. So since I
Okay.
have already planned to go to Surabaya next week, but I'm
Next
sure
week.
I will join the journal club.
Okay. So I could help you with the journals, could find the journals, and also you just read it and prepare presentations. And it's going to be good to have the aspect on reconstructive surgery. What do you think?
Uh,
No, it's not a force. It's not
oh,
mandatory.
yeah. Actually, I would like to, but I'm not sure. But next week I will be available since I have to go to Surabaya to visit my family.
Yeah. No problem. No problem.
I'm
Make
sorry,
sure
sir.
that make sure that you are safe visiting Surabaya. And I believe the tone of the red zone is decreasing already, right?
Yes.
Oh, good.
Apologies, sir.
Okay, thank you. Any other concern to discuss? If not that, yes? Okay. Mandy, are you there? You would like to say something? All right. So I think it would be good to let you know. I believe many of you have realized that we could get the access on HEI, which is a service given by the ASS, find many videos so that by demand you could find anything that interests you. Uh, Let me get favorite videos. I think here is favorite video. This is just an example where you could find the example on the discussions on flexor tendon lacerations, and it discusses the science and also the rehabilitations beside the repair and many more, hundreds of videos that you could learn. And it's going to be good also for you. I would like to invite you to go for online survey Let me type this for you. Okay, so that I could give you in the chat box.
Okay.
This is the link for, yeah, this is the link for you to join the survey.
Actually, you also mentioned this one on the group, right, sir?
Right, right. So because they need more response because they have given a focused attention to Indonesia. It's going to be fantastic that the ASS8 is going to be providing support with educations to Indonesia. So why would us neglecting the offer, which is good? And I know the quality of the people behind the desk. They are Professor Kevin Chung, which is one of the most famous person in the world with the most publication in terms of numbers and also quality. And he is going to be taking over the positions as the editor-in-chief of PRS. So why would you not trust this gentleman? And he is the current president of the ASSH. So what are we waiting for, right? Yeah. And so he works together with Professor Lalonde, to whom that, you all know about his reputation. He is one of the greatest teacher traveling the world, promoting the idea of providing best service in hand surgery. And so with the most famous with the tumescent injections, with the Wallan technique. So those two persons behind this, all the work, focuses to Indonesia, all right?
Yeah, I get the schedule in August.
Right. What do you mean with August? The schedule of what?
They will call you, right? And they pick a schedule to, then they will contact you on that schedule.
Right. So yes. I was the first one to get interviewed. They need 30. I mean, the group in Michigan University, in collaboration with the ASSH, have the survey research, not only based on the writing survey that goes through this link, but also they would like to have interview, deep depth interview with 30 surgeons. That may include plastic surgeons or orthopedic surgeons, and also with some residents. A depth interview would take you about 40 to 60 minutes, depends on how you would respond to the questions. All right. And it was good. And what they asked was basically to explore the type of learning, whether we Indonesians would be categorized as learners by listening, by reading, or by vision. So it's going to be good to provide them with particular tailorized program based on the research. So it's going to be fantastic to respond to them, not only based on the survey here through the link, but also based on the in-depth interview. Okay. So please tell our colleagues, not only from me, that they need to support to put their name into the list that I would share it in the group, and provide yourself with, timing. Yeah. Also, they would confirm it individually with all of you who would volunteer to be interviewed. Yeah, I get the email to pick a date. So yeah, I just wait to them to contact me. Yes, good. Yes. All right. Okay, then if we don't have more discussions, I think we should end this journal club, and all of us thank Elisa to put us into learning session, which is good. Thank you all. I hope we get, even though just a little bit, but a reminder about hand tumors this night. Right. Okay. Happy Eid Mubarak. Yep. Have a nice evening, and see you next week. See you next week. Thank you.
Bye.
Bye, everyone. Thank you.